Welcome to the AETCM channel. Today we are going to discuss a case of a breathlessness condition. A female came with breathlessness condition. Initial 10-second assessment. Patient was tachypneic and normal color in responding to our commands.
Just wait a second. Patient tachypneic, normal color and responding to commands. Okay. So primarily, what do you think the issue might be here?
Something to do with breathing system.
So something to do with
breathing.
The initial 10-second assessment, you have found out that the patient is tachypneic and she is responding to commands. So airway patency is okay, but breathing part she is tachypneic. So we need to address that issue. So oxygenation we need to look in for. Respiratory rate is on the higher side. Okay.
In the primary survey, in the airway, the patient was able to talk in one full sentence.
Okay.
There were no any gurgling or hoarseness of sound, any tongue, fallen tongue, or any pooling of secretion. So airway is patent. And then breathing, the respiratory is 20-20, and the SpO2 is 99% at the rate of 4 liter oxygen.
Okay. 99% on 4 liter of oxygen. Okay.
As she was tachypneic, we connected oxygen immediately, and 4 liter of oxygen, so it was 99%.
Okay.
And chest movements was symmetry, and there was no any use of no acid.
So since you said tachypneic, she was not that grossly tachypneic. The respiratory rate was only 20. Maybe after starting the oxygen, the rate might have settled. Because initially the patient came in itself, we found tachypneic, we put her on oxygen, and SpO2 improved to 99% on 4 liters of oxygen. So on examination of the respiratory system, we found out that
there was bilateral infrascapular clefts present.
Bilateral infrascapular clefts only. That is the only thing that you are able to elicit. Otherwise, everything was fine. Okay.
In circulation part, BP was 150/90, heart rate was 66 per minute, the peripheral pulses are palpable, and the capillary fill time was less than 2 seconds. There was no any active bleeding.
Okay, so what do you comment on the circulation? Higher side BP, 150/90. What would be the reason why she is having
hypertension?
The patient can be non-case hypertension, maybe the breathlessness, the hypoxia would have triggered that hypertension. But funny thing is that heart rate is only 66 per minute. So what should be the usual thing that you will anticipate here? Heart rate of 66.
If she's taking some beta blocker.
See, ideally the heart rate should go up. That is what the usual response should be. Ideally the heart rate should be above 66. It will be above somewhere around 100. Because when there is hypoxia, the blood pressure and heart rate also can increase. But the problems that heart rate is not increasing, we need to see. Why there is no increase in heart rate? What you said, the patient might be on beta blocker. So that is one differential diagnosis. What would be the other reasons? Why she is having a heart rate of only 66 per minute? You said peripheral pulses are all palpable. There is VRT is less than 2 seconds. So what would be the other reasons of not that having a gross tachycardia with this amount of hypoxia that she was having? Can you just think? What could be the causes? One thing that you said is the patient might be on beta blockers. Okay, and accepted beta blockers. Okay, then two. What could be the other reason? What is a lady heart rate is not very high? What could be the other reason? Most common thing you have to consider is hypothyroidism. Whether there is any hypothyroidism underlying. Hypothyroidism. That is the next thing that you need to keep in your mind. Then 66 per minute, any rate limiting. For that reason, beta blocker, calcium channel blockers, which can decrease the heart rate, you need to remember. Digoxin, all these rate limiting drugs that you need to consider. Second is hypothyroidism, that is another differential that you need to think. What would be the third reason why she is having a not very high tachycardia? Can you give me some background history about this patient so that you can?
She is a known case of CKD patient.
CKD. So CKD, chronic kidney disease. So what all things can happen in CKD, which can cause decrease in heart rate? No, think. What is the electrolyte abnormality most common? Potassium. So hyperkalemia. It can be a part of hyperkalemia. We don't know. It can be hyperkalemia related ECG. Acid hyperkalemia can have this. Then you can have metabolic acidosis. And then again they can have all those dyslipidemias to start off with. We doesn't know what exactly the rhythm is right now. We are just seeing that heart rate is around 66 per minute. We need to take a 2-lead ECG and see what is happening to her. So these are just in a nutshell. What can happen when she is having a uremic pericarditis? Usually it will be tachycardia. So it's more in favor of a tachycardia. Uremic pericarditis. But uremic pericarditis, the patient can otherwise, what is the age of this patient?
66 years.
66 years. What could be the other reason? Maybe a sinus node dysfunction, but heart rate is not very low to call it as a sinus node dysfunction. When it's less than 50 and the patient is symptomatic, after taking an ECG only we can comment on this. But at this juncture, we need to keep, usually we will see an increase in heart rate, but here we are not seeing that. We should have suspicion of something is going wrong to this patient. Whether she is already on a beta blocker, calcineurin blocker, which is limiting her heart rate to be increased, hypothyroidism, another differential that you need to consider, hyperkalemia and metabolic acidosis. So these four things you need to remember. Since she is a CKD, we got the clues.
Yes.
Otherwise also we just can, some electrical disturbance always you need to keep in your consideration. Okay. So you can go to the next thing. So circulation wise, heart rate we are not very happy. Why there is having a decrease in heart rate? We need to check it out. Okay. Now.
Next, the disability wise, GCS was full, sir, E4, V5, and 6. Pupils are bilaterally 2 mm symmetrical and reactivity is present. GRBS was 330 mm.
330. So, are you happy with the GRBS? No, it's on the higher side. So, it's on the higher side. So, random sugar is on the higher side. Okay.
In the exposure, patient has the normal body temperature and we prevented hypothermia by providing the plan.
Okay.
Next, the adjuncts to the primary service of GRBS was.
You already said.
In the ABG wise, the acid base status was metabolic acidosis with compensated.
So, can you just calculate how you came up with metabolic acidosis, or I will do for it? You tell me the pH is 7.33. So, it is decreased. Okay. So, PCO2 is 33. So, it is also decreased. Right? It is also decreased right now. Bicarbonate is 20. It is also decreased. Then, what is the main reason why you are telling that primarily it is a metabolic issue rather than you are telling it is a primarily, I am telling you why not it is a respiratory issue. So respiratory acidosis, what will happen? PCO2 will increase, but here PCO2 has come down. That is what is happening in metabolic acidosis. Why there is a decrease in PCO2 in metabolic acidosis? For a compensatory mechanism, it is trying to compensate because there is a lot of H plus ion loss. So it is trying to compensate by doing carbon dioxide washout. So that is a normal mechanism. So we need to calculate the expected PCO2 for this bicarbonate by using the Winter's formula. So that is what is Winter's formula? 20. So we have to take 20 as the bicarbonate, 20 into 1.5 plus 8 plus or minus 2. Plus or minus 2. So this is the Winter's formula. So how much it will come to? It will come to 38 plus or minus 2. So here it is 33, which is on the lower side. So what you can say, there is associated metabolic acidosis along with respiratory alkalosis also. So both metabolic acidosis and respiratory alkalosis. Suppose this patient is having a PCO2 of 38. What we will say? It is a compensated metabolic acidosis. That is what, because the PCO2 compensation has occurred to whatever it is required. So 38 is what is expected, but she is only having 33. So that is the reason why we are saying there is a metabolic acidosis with
respiratory
alkalosis. Okay, so that is the calculation what we have done. Now we have to see metabolic acidosis. Once you see metabolic acidosis, what is the next thing that you have to calculate? You have to calculate the anion gap. Remember that next thing you have to calculate is the anion gap. We have to know whether it is a high anion gap metabolic acidosis or a normal anion gap metabolic acidosis. So what is the anion gap here? You have the lab values. You remember?
Yes.
You have put it in here. Okay. So we'll just check. You have put some investigations here, right? So we just check
the potassium of 6 point.
That you have written. I wanted to know the chloride only. You have ABG value?
Yes, sir.
Yeah, you can just tell me the chloride value.
Chloride is 106.
We'll just go there. Okay. 1, 2, 3. Okay. Chloride. So anion gap is equal to how much? So we have to calculate sodium
plus potassium.
Potassium we leave it. Sodium minus chloride is how much?
106.
Chloride with bicarbonate.
Yes, sir.
So CO3. So that is sodium is how much here?
Sodium is 151, sir.
151 minus chloride you said?
106.
106 plus 20. So that is how much is 126. So it is coming as 25. The anion gap is 25. So high anion gap metabolic acidosis. So we have got a patient who is having a high anion gap metabolic acidosis. So when you get an ABG picture like this, so we have to see the first thing whenever you get a metabolic acidosis, first thing what is the compensation? Whether it is adequately compensated or there is an associated other disorder. Then there is the next thing you have to calculate the anion gap. Once you see there is an increase in anion gap, what is the next step? We have to go for the next step. So that is the next step. We have to always look for osmolar gap. So that is the next step that we need to do. We have to go for osmolar gap. So osmolar gap is what we have to do to the serum osmolarity, and you need to subtract from the calculated osmolarity. So osmolar gap, if it is more than 10, if it is more than 10, it is high. So the patient has consumed some toxic alcohol, especially methanol, ethanol, they are coming with toxic ethylene glycol, toxic alcohol ingestion, they can have this high osmolar gap. So once you see a patient with metabolic acidosis, first thing you look for compensation, adequate or not adequately compensated. The next step what you need to look in for is the anion gap. Once you get the anion gap, you have to look for high anion gap or normal anion gap. If it is high anion gap metabolic acidosis, what is the next thing that you need to look for? Osmolar gap. Now what you have to do? We have to look for the third disorder. No, we can have three disorders in a patient. So that is you have to look for delta anion gap divided by delta bicarbonate. So basically what do you mean by delta?
Change in the anion.
So anion gap is here, it is almost 25.
Yes.
We have calculated 25. Normally we will take it as 12. So delta anion gap is 13.
Yes, sir.
Here, right? You understood, no? How we came up to?
Yes,
Because 25 minus 12. So we got it as 13. What is bicarbonate? 24, we take it as normal. So it is 4. So 13 divided by 4, it is more than 1. It is more than 1. What is the inference? There is another disorder. There is also an associated normal anion gap metabolic acidosis also. So you can have a triple. I am not complicating since you have just started learning this. So first step I will tell you have to calculate is compensation. Whenever you see a metabolic acidosis, look for compensation by calculating the expected PCO2. Expected PCO2. The next step you have to calculate is the anion gap, then osmolar gap, then you have to go for delta anion gap by delta bicarbonate. So we can have a patient can have triple disorder. We have found out this patient is having a metabolic acidosis with respiratory alkalosis with normal anion gap metabolic acidosis also. So these three things can be simultaneously seen in a patient with a metabolic acidosis. So we have to see. So now I am asking you a question. What will be the clinical importance of this? See, why I am telling this, this patient is having, suppose you take a patient with diabetic ketoacidosis. Imagine a patient with diabetic ketoacidosis. So what is diabetic ketoacidosis? It will cause high anion gap metabolic acidosis. Understood? So what is the treatment for high anion gap metabolic acidosis in DKA? You need to give him fluids. Okay, so fluids contains what? Chloride. So chloride does what? It will cause hyperchloremic metabolic acidosis. Okay, so the patient is having a DKA initially. You started treating him with fluids. He went into high anion gap metabolic acidosis. He had a high anion gap metabolic acidosis. Along with that, he is having a normal anion gap metabolic acidosis later on. So this thing has happened to a patient. Then why there is respiratory alkalosis? Imagine the trigger was a pneumonia. Okay. Suppose the patient had a pneumonia, what will happen? The patient respiratory rate will increase. Okay. So as a result, there can be carbon dioxide washout. The patient was going for a respiratory failure, what can happen? The PCO2 buildup can happen. There can be associated type 2 respiratory failure also. Here this patient only had a type 1 respiratory failure. So that is the clinical significance. You can have 3 disorders in a patient that is coming to you. Understood? So we have to carefully analyze every ABG that you are getting. Just telling a basic thing is not enough. You have to see why this is happening. Now we have to find out why this is happening to her. Why there is a metabolic acidosis. Why there is a respiratory alkalosis. Potassium is on the higher side. So that gives a clue that she is already a known case of CKD. Since you have said, I know that. Yeah. So that might be the reason for this, and maybe some impending respiratory issue, maybe some fluid condition that is causing her increase in respiratory rate. Okay. Now,
at the same time, high glucose also should not.
Yes, decay. It can be also possibility of a decay. She has got a high. Whatever we have discussed is a possibility. Exactly 330 sugars. Yes, 330 sugar. It can be decay, but usually in DKA, you can have potassium also is elevated. That is fine. Once you can, one easy thing that you can remember, usually acidosis, metabolic acidosis along with hyperkalemia. Along with hyperkalemia. Metabolic alkalosis will be with the hypokalemia.
Okay.
So whenever you see metabolic alkalosis, potassium usually will be low. Whenever there is metabolic acidosis, potassium will be high. So that is what we are seeing here also. Okay, so there can be different reasons why she is having a metabolic acidosis. We have to see whether we have to look for a ketones and see whether the ketones are trace or positive. If it is positive, then we have got another diagnosis of DK with CKD with respiratory alkalosis. So whatever we have discussed is going to happen for this patient also.
Yes,
Okay. Yeah.
Then we have taken the chest X-ray.
Okay.
In the chest X-ray here, there are some non-homogeneous.
Okay. See, there are certain gross things that you will be able to see here. What you said is right. There is an haziness in this part. We just scrub that off so that they will be able to see. See, the cardiophrenic angle here and here, it is blunted. So that is the first thing. So whenever you are looking at a chest X-ray, you're like, how does you look the exposure? I don't think exposure is not very great, but it looks central but little bit rotated. That is okay. Whether it is a PAV or an APU, it is an APU, so we can't clinically comment on cardiomegaly, which I am able to see a very gross cardiomegaly in this patient. But this, since it is an APU, we will not be commenting it here. But only thing what we can, both the CP angles are blunted and exposure is not very great in this X-ray, and there can be certain amount of pleural effusion. There is some peribronchial, this area, there is some fluid overload or early peribronchial changes are there, so that can be attributable to an early evolving pulmonary edema. And here also it is rotated, we cannot comment on this area also. So these are the comments from the X-ray findings. Okay,
then ECG was taken, sir. In ECG there was T-wave inversion in V6 and ABL.
T-wave inversion in V6 and ABL. So it's a lateral lead. So it's a lateral lead. So what is a normal, why she is having a lateral T-wave inversion?
The hypoxia related changes.
Okay, see, whenever you see a T inversion, what is the next question? I will ask you only one thing. No, it is a symmetrical or an asymmetrical T inversion. You can have different types of T inversions, okay. So one is both the limbs are symmetrical, like this. Okay, this is always most commonly when you see this ischemia or deep cerebral T waves and all those things. But whenever you see one limb is more than like this is more commonly seen in a strain pattern. So we have left ventricular hypertrophy. So all these strain pattern you will get a T inversions like this. So I want to know whether the T inversion was like this or whether it was like this. If it is like this, we need to consider hypoxia and not hypoxia, ischemia to the heart. That is a non-ischemia. Any of these things can be a possibility. But since potassium is on the higher side, it is not due to hypokalemia. Usually hyperkalemia, what are the changes that we anticipate?
Hyperkalemia,
tall tender T waves, widening of the PR interval, then QRS complex widening, then sine wave pattern, and finally arrhythmias. So that is what will happen in hyperkalemia. Okay. Then ECG you discussed that.
And we attached the cardiac monitor.
Okay.
And the bedside assessment of IVC was done using USG. It was distended and not compressed.
Okay, that is again an important information that you have suggested here. You have done an IVC examination and you found out that it is distended and not compressible. So what does that indicate?
Volume overload.
There is a volume overload condition. So that is one thing that we can see. But edema was there for this patient? Yes. That itself can give an idea. But if you don't have any USG, simple thing, look for edema. Okay.
Yes,
and Foley sterilization was done. Okay.
Next, coming to the secondary service.
Okay.
Regarding the allergies to the medications, there were nil, sir. And in the past medical history, she is type 2 diabetic for the last 13 years.
Okay.
And the complication of diabetes is non-proliferative diabetic retinopathy, for which PRP was done. Sir.
Okay.
And she has known case of hypertension for the last 7 years.
7 years.
Yes.
Drug history? Any drugs that she was on?
Yes, sir. She was taking beta blockers.
Beta blockers. Okay, so that gives us the reason of bradycardia there. Okay.
And then she is a known case of CKD, sir. Previously, her baseline serum creatinine was 7.5.
Okay. Okay. So
and
that
is not on hemodialysis.
Okay. So right now she's on own CKD, maybe a stage 3, stage 4 CKD, but maintaining your output till now. Yes. And she was never initiated on hemodialysis. Okay.
But got to know that she had a graft was made, that AV fistula was made.
Already made, kept ready,
Kept
thinking
ready.
that she's going for a stage 5 renal failure. Okay.
And in previous, there was an enstemia acute coronary
History, so
syndrome.
that the ECG changes were
At that time there were 3 inversions in 1 and AVL.
Okay.
This time there were in V6 and AVL.
See, V6 and AVL. V6
So
and AVL. Both represents the same part of the heart. Maybe something lead position or something would have changed, but usually it represents the same part of the heart. That is a lateral part. Okay.
And the last meal was 8 hours ago. The events relating to this incident were she had developed sudden onset breathlessness in 6 hours.
Very important. Sudden onset breathlessness. Okay.
It was NYHA class 4. The baseline was NYHA class 2 for herself. And she was having orthopnea.
Orthopnea. Okay. So this all gives a history of probably she's having a fluid overload was there and sudden worsening would have happened. So it is an evolving thing. It is not like 1 second it didn't happen. Over a minute it didn't happen.
Yes.
It was gradually building up and last 6 hours she became worse.
Yes.
Okay.
And like other past history wise, she was saying she was having dental pain 2 days ago.
Okay.
Just
That is a very significant history because that pain would have triggered her this thing. So there can be 2 reasons whether she has taken any NSAIDs and renal function can worsen. That is one thing that you can keep in mind. But usually they will go and take the creatinine on the higher side. Usually the doctors won't prescribe NSAID. But that pain itself can precipitate a pulmonary edema. So the pain for like a patient who's having a borderline creatinine and everything like this, not borderline means 1.5. This is like 7.5 because she's very prone to develop pulmonary edema at any point of time. She's having a cardiac issue as well as a renal issue.
Yes.
So that pain itself can precipitate this. So that could be the trigger that has happened right now.
And there is no any history of any fever or any abdominal pain or reduced urine output or any chest pains.
Okay.
And she actually visited the outside hospital and there they had given her Lasix and nebulized with Duolin for her breathlessness condition.
Okay.
She came.
Okay. Continue.
Now in the examination.
Anything significant other than for this speed of it? Okay.
Showing the volume.
Okay.
And in respiratory examination.
We have already concluded anything additionally that
No,
we
sir,
have
bilateral
interpretations were processed. Okay.
Already taken Lasix injection, so
Okay.
they are on the low.
Sure.
And now coming to the lab.
Yes. Now we will evaluate here. No.
Basically, the CKMB value being in the normal set shows that there is no any acute coronary event going on as of now.
Okay.
Chest octanes being high says that because of CKD patients might be
it can be a false positive.
false positive.
False positive. Then CRP of 2.71 indicate there is no active infection. Again, creatinine of 7.92 and 150 of urea. That is again on the higher side. Anything else?
WBCs are little bit higher side.
Little bit on the higher side. That can be due to your any of this information.
Also, it was having the picture, so we can.
It can be just a part of your inflammatory process, whatever she's having. Just she's having some breathlessness. Need not say that she's having any infection. It can be the process of inflammation. Potassium again, it's on the higher side, attributing to her CKD. Then
Hemoglobin
9.7 again CKD. It can be part of her CKD because of the erythropoietin decrease in the erythropoietin. And your
liver function tests.
Everything was okay, OTPT, everything is fine, and you only have non-reactive, everything it's CD, everything was non-reactive. That is very important because therefore planning for a dialysis, we need to use a machine very safely. Okay, if the patient is positive, you need to use those specific machines. That's the only thing. Okay, fine.
So now the interpretation till now with the lab investigation and everything is looking like a fluid overload.
Okay, done with any additional pages are there? No.
Not this, just
Okay,
it.
so just we'll add one page. Okay. So you can write down your diagnosis now.
Nephrogenic
pulmonary edema. Okay. Nephrogenic pulmonary edema. That is your differential diagnosis. Trigger can be an underlying CKD, maybe this dental pain, or we need to always consider she's a fluid overload. ACS patient is there. She's already an ACS patient. Another thing what NSAID can do is a fluid retention. Okay. So that is another thing. He has taken some fluid painkiller that can cause fluid retention, that can trigger all these events. So just keep that in mind. It is an nephrogenic pulmonary to be right now, unless and until we are proving it by doing an echocardiography and ruling out that the LV function is fine. Primarily looking like a nephrogenic pulmonary edema. Now this patient is in the ED. So can you just write down a detailed prescription? You can just wipe that off. So detailed prescription, what I am asking is what all things that you need. You said the patient is on an oxygen.
Yes.
So whether you need to add on, you need to put her on something else.
So depending upon her respiratory rate, if it is more than 30 or so, like tachypnea, we can consider BiPAP, sir,
Okay.
to control her respiratory
Okay.
rate.
BiPAP is one option.
Yeah.
Definitely yes, nephrogenic already one. Less than 30.
Less than 30, we can go for medical management.
Medical management. So what are the medical management that you want to give?
Medical management wise, first we can start with the injection diuretics, sir,
Okay.
so that we can reduce the fluid overload.
Okay. So what is the medication that you wanted to give in here? Diuretics.
We can start with injection furosemide.
Furosemide. See, again, a lot of people will have doubt in their mind. How much furosemide should I give? Whether, especially this patient, they are very okay. But the other question they will ask, suppose the BP is 90/60. Can I give furosemide? Furosemide will cause hypertension. So that is what they are. See, there is an extra fluid overload. You are trying to remove that extra volume. So if you have any doubt, like 40 mg of Lasix is not going to do you any harm. But you have to understand, if you have any doubt in mind, start the morning infusion, which is going to be taking a longer time. But definitely this patient, we don't have any issues. So we can easily give on 60 to 80 mg of Lasix start as for this patient, whatever dose she has received previously, because already we are concerned only with Lasix is one thing is hypokalemia. But here it is hyperkalemia. So that is again going to help her here only. So we can easily give 60 to 80 mg of Lasix start followed by a continuous infusion. Well, since he is significantly improving at that time, we can continue the infusion. So furosemide is the first drug. Okay. Then next drug. Now 150/90 BP are okay. You don't need to start any antihypertensive. Whatever she is taking, she can continue. Suppose imagine it is like 210 over 120.
Then we can start with any nitro and go like nitroglyceride, this nitroprusside kind of.
Nitroglycerin is an ideal agent. Hydroglycerin,
yes, it will do fluid also, it can remove.
Nitroglycerin, hydroglycerin, very good agent. But labetalol?
So labetalol just only.
It's a transient thing. It is not going to help you for a long time. But what you have to oral antihypertensive, you start oral hypertensive because their BP is going to be on a higher side always. But we can start with NTG option. Then, if needed, we are not going to give for this patient right now. Lasix and BiPAP usually settles this patient, and insulin sugars are on the higher side. So what you will give? You want to start her on an infusion. That is an ideal thing because you are putting her on a BiPAP. Maybe you are putting her on a BiPAP. Feeds is going to be low, but by giving a start dose, we are not going to monitor that. So depending upon the sugar, you start with your Delta protocol. You start with somewhere around 3 units per hour as an infusion, and here the tricky thing is that if the patient is already having a DK also. So DK with this thing, then it is going to be difficult. Lasix, again, we are going to dry up the patient. So again, the DK is not going to settle. So we have to have an issue here with balance, how to do the fluid balance. Since you said IBC is already discontinued, she might not have a DK. So serum ketones, I hope it was negative. It was more like a hyperglycemia only.
Yes.
That's what we are seeing. And metabolic acidosis was attributing to the renal failure. Okay.
So we can start with injection, human actripid.
Human short-acting insulin, we can start as an infusion.
Yes, sir.
No problem. Then, what else? That is actually, that will be the only thing that is needed right now for her.
Emergency per se.
Emergency per se, that is the only thing. We just need to hyperkalemia management 6.1.
Yes.
You are giving furosemide and atrapid. That will help, but it is only atrapid only will
start
shift.
with calcium gluconate to protect the heart.
But 6.1 CKD, if you feel like there is any chance of arrhythmia, you can definitely go with calcium gluconate. Potassium binders, you can try with potassium binders, and ultimately dialysis. So potassium you need to keep in mind, but these two things also will help to decrease the potassium. Furosemide will remove it from the body, and atrapid also will shift only. It will not remove, it will only shift the potassium. And other thing that one other question, Naveen, I want to ask. Suppose this patient is having 300 sugar. So suppose somebody is coming and writing GA bonus. You wanted to give a GA bonus or insulin is only enough.
Insulin alone is enough.
Insulin is the main thing. Suppose the patient is already having hyperglycemia, no need to give dextrose again. So why we are giving dextrose is basically to prevent hypoglycemia or whatever insulin we are giving. So
Yes.
glucose is not the main thing. So that is one concept that I want you to make it clear.
Yes.
When the sugars are on the higher side, just give the insulin alone. That is enough. Okay.
Yes. Apart from this, coming back to the dialysis in question, if the patient is having persistent hyperkalemia.
So what will be the indication for dialysis? We can put that way. Yes.
Indications for emergency dialysis would be the pulmonary edema itself.
Okay.
And this may hyperkalemia, as in this case,
Yes.
which we are going to see. And other things is
Severe acidosis.
and the hypertension part if it is not being controlled.
Okay. So here she's settling with your oxygen therapy. Right now, settling with oxygen therapy. BiPAP, if needed, we can start. We have not done that.
With the help of Lasix, we control.
We control the hyperkalemia. Persistently, it is high. She will be a candidate for hemodialysis. Acidosis is not to that great extent. Just a borderline acidosis only there. So maybe with this, all these drugs, the patient might improve. Okay, how is the patient right now?
Patient is
Significantly, they dialyzed her or
no,
without dialysis she improved. Okay. Anything else that you need to add on?
Treatment wise.
Whatever we have discussed, everything it has come up already.
Yes.
Okay. Anything additional? Nothing, right? Okay. Thank you.
Okay.